Test 1, 2, 3, 4, 5. Sounds good. start yet.
Okay, I won't.
Okay.
Okay. Welcome back to the hospice item set training. This is day 2. Glad to see everybody out there in the audience today. Today is February 5th, and I'd like to let you know that yesterday, for day 1, we had a nice audience here in person, and our live streaming number was 1,300 people watched the presentation. So we're really happy with the participation by the hospice community. So as I said, we do have live streaming going on today. You will have another chance to view this material once the live streaming tape is converted and edited so that it can go up on the website. So you will be notified of when that's available by way of the Open Door Forum, which is March 5th, and or the Hospice Quality Reporting website. Okay. Today we'll do the same thing as we did yesterday regarding questions and answers. So we will be able to take questions that are written down on the note cards from the live audience. And those questions will be reviewed and answered today. For the participants that are viewing this by way of live streaming, if you have a question, please hold on to it. If it's not answered in any of the sessions today, then please send it in to the help desk and make sure that you reference, if you can, the area in the manual, the HIS manual, and or the slide numbers. And please put your email address and you will receive an answer to that question or questions. So for today, the overview for today, first up we'll have answers to the dyspnea questions that came in yesterday. And then we'll move into section J, which is pain, and then section N, which is medications. Then we'll have a break, probably 25-minute break. And then we'll have the question and answer session for the questions received from the in-person participants on pain and medications. Then we'll move into section F, preferences, and then finally we'll have the questions and answers on preferences. Then we'll have a wrap-up at the end of the day. So that's what today looks like, and we're happy that you're participating, and I'd like to turn it over to Francie at this time for some questions and answers. Thank you.
Okay, good afternoon, everyone. I'm going to get set up here and raise this guy up a little. So we'll start with questions that we've received about the dyspnea section that folks submitted yesterday. And the first question is, what do I do if the patient's information changes? It seems like you provided different answers for the dyspnea section versus the other question about opioids that came up during the first question and answer session yesterday. And that's a really good question, and several of you have raised it. So the answer is, what you do depends on what the item is asking for according to the manual. If the item is asking for the first dated care process, such as the items for the most part that are contained in the respiratory, the pain, and the preferences sections of the hospice item set, then the first screening or dated discussion with the patient would not be impacted by subsequent screenings or discussions. Therefore, your hospice's response to this item on the hospice item set will not likely change, even if the patient subsequently has a positive screen for dyspnea. For the opioid and bowel items in section N, those items on the hospice item set are not looking for the first prescription. And this reflects a difference in how that measure is specified and endorsed. And you can view the details on those specifications in the Appendix C in your manual. For all of the items on the hospice item set, the hospice does have until 14 days after admission to complete the items and ensure that the hospice item set accurately reflects the information in the patient's clinical record. And this means that items can be updated or corrected until the 14-day completion deadline for the hospice item set on admission and the 7-day completion deadline for the hospice item set discharge. But again, what you do depends on what the item is asking for in the hospice item set. So a related question, number 2 here. So on admission, dyspnea screening results in a no response. And on day 12, the patient now has dyspnea and interventions were initiated. Do we update the record? And so again, this goes back to what I just said. The dyspnea item J2030, which is about the screening, on the hospice item set is looking for documentation of the first screening for dyspnea. So the results from that first screening will not be impacted by subsequent screenings, and therefore, your hospice's response to this item is not likely to change. Okay? So that would be even if there's a subsequent screening. Okay? So the measures and these items are about the first screening that took place. The third question is, what is the time period under consideration to report the patient's shortness of breath? So for example, a patient states he gets shortness of breath when going to the doctor's office. Is that a screen? And is the screen date the date of the assessment? And would item C be answered as yes or no? And the answer is that CMS does not dictate when the screening should take place. It's possible that the screening will have taken place during the initial nursing assessment or at another time. The purpose of screening, which is asking the patient about shortness of breath experience and its severity, is to identify whether or not the symptom is present, and if it's present, its severity and the effect of the symptom on the patient's well-being. The item J2030 records whether or not the clinical documentation shows that the patient was screened for shortness of breath, but does not dictate what the screening has to include. It is possible that a statement such as patient gets shortness of breath when goes to the doctor's office would be part of that documentation, but this would not reflect clinical best practice in which a screening would indicate both the presence and the severity of symptoms. So in the example you gave, we would not consider that to be a screening as defined in the hospice item set manual. Next question. If the abstractor finds the clinical record to say, patient reports frequent shortness of breath, no shortness of breath noted during assessment, should the abstractor consider that a screening for shortness of breath occurred? Can a patient's subjective statement be considered an adequate documentation that a screen was conducted? Must screening indicate severity or just the presence of shortness of breath? So a screening is needed to inform the appropriate treatment for the patient's symptoms, and a screening should include both presence of shortness of breath and, if present, the severity of the symptoms. The severity does not have to be rated using a standardized screening tool, since structured evaluation of dyspnea is not well defined. Okay. The screening might include the patient's report of the presence and severity of symptoms, as well as objective data collected by the clinician conducting the screening. Now, in the example in your question, there's documentation that the patient reported shortness of breath subjectively, but the documentation of screening by the clinician does not indicate that the patient, who in this case is capable of reporting, was asked about the severity of these symptoms. And therefore, this example does not meet the definition of screening as defined in the Hospice Item Set Manual. The next question is, please clarify. Item-specific instructions for J2040 say that treatment initiation is defined as the date a verbal or written order was received to initiate treatment. So if an order was received on August 12th, but initiated on August 13th, which date is reported? For item J2040, you enter the date of the order. And this is because it can be very difficult to find documentation of when the first treatment was actually delivered to the patient. So in the HIS manual, we define the treatment initiation as the date the order was received. And the next question is, if opioids or other medications are increased rather than initiated, are they still checked in J2040? If opioids or other medications are increased to specifically treat dyspnea, then an order for the change in dosage would be in the clinical record and should be considered in selecting the correct code for item J2040. And our last question is regarding situation A in the Hospice Item Set Manual on page 2J15. The last sentence says, morphine could be considered a treatment if shortness of breath as a reason for the medication is listed. Is this true even if the medication is not administered prior to completing the abstraction? So in situation A on page 2J15, the initiation is defined by the date of the order, not the date that the first dose is delivered. If the order indicates that the opioid, whether PRN or scheduled, is prescribed to treat the symptom of dyspnea, then it would be considered in responding to item J2040. Okay, these are the questions for the dyspnea section we've received, and now I'll turn it over to Alexis, who will start us into section J, the items related to pain. Thanks.
Hi everyone, good afternoon. Again, my name is Alexis, and I'm going to be walking you through the items related to pain in our first session today. So if you'd like to follow along in the Hospice Item Set Manual, the pain section begins on page 2J1. Pain is a prevalent and undertreated symptom for many populations of seriously ill patients, including those at the end of life. Pain management is rated as a high priority among patients and their caregivers. The consequences of inadequate screening, assessment, and treatment for pain can include physical suffering, functional limitation, and development of apathy and depression. Pain screening and assessment are critical steps in quality pain management and treatment. So the two care processes that are covered in the pain section in the hospice item set are going to be pain screening and pain assessment. So looking at this first care process, which is pain screening, the relevant item in the hospice item set is J0900. And J0900 is used in the calculation of the corresponding quality measure, which is NQF number 1634, the pain screening measure. The second care process is pain assessment. and the corresponding item is J0910. This item, J0910, is used in the calculation of NQF number 1637, the pain assessment quality measure. Taking a closer look at both of these quality measures, NQF number 1634 measures the percentage of patients who are screened for pain during the initial nursing assessment. NQF number 1637 measures the percentage of patients who screened positive for pain who also received a comprehensive pain assessment within 1 day of their pain screening. And more information about both of these measures can be found in Appendix C of the Hospice Item Set Manual. So similar to the 2 shortness of breath quality measures that I presented on yesterday, these 2 pain measures, NQF 1634 and 1637, are also paired measures. So this means that the pain assessment measure looks at elements included in the comprehensive pain assessment only among patients who screened positive for pain in the previous quality measure. When you're completing the hospice item set, in practical terms, this means that if a patient did not screen positive for pain, you will not complete the comprehensive pain assessment item. Our first item in this section is item J0900, which is the pain screening item. This item can be found on page 2J1 in the Hospice Item Set Manual. For this item, you are looking for evidence in the clinical record about pain screening. J0900A is the first part of the item, and it asks, was the patient screened for pain? So hopefully from yesterday, you should now recognize J0900A as our gateway question, and it's going to tell you whether or not the care process took place. In this instance, we're talking about pain screening, so we want to know if the patient was screened for pain. You should review the clinical record to see if there is evidence that the patient was screened for pain. Based on evidence found in the clinical record, you would answer either 0, no, or 1, yes, to J0900A. And remember here, if you answer no to the gateway question, which is J0900A, you will skip the remaining parts of this item, which are B through D, and you will move on to item J2030, which is the screening for shortness of breath item. The next part is J0900B, which is the date of the first screening for pain. So I'm going to allude back to what Francie was just talking about in her first Q&A that she presented on today. And I want to note here that J0900B and this entire item is talking about the date of the first screening for pain. So you should complete this item based on the first screening that you see documented in the clinical record. And this means that if there are multiple screenings documented, that those should not be considered when completing this item. You complete it just on the first dated screen. So if you answered yes to J0900A, you would record the date of the first pain screening here in J0900B. J0900C asks, what was the patient's pain severity? And again, based on evidence in the clinical record, you should indicate the patient's pain severity score here in Part C of the item. So you would select code 0 if the patient's pain severity score was none. This would include a score of 0 on a 10-point numeric scale, or an equivalent score on a verbal, visual, staff observation, or other numeric scale. And if the patient had no pain, you are going to skip Part D of the item and move on to item J2030, the screening for shortness of breath item. You'll select code 1 if the patient had mild pain. This would include a score of 1 to 3 on a 10-point numeric scale, or an equivalent score on a verbal, visual, staff observation, or other numeric scale. You would select code 2 if the patient's pain was moderate, which includes a score of 4 to 7 on a 10-point numeric scale, or an equivalent score, again, on a verbal, visual, staff observation, or other numeric scale. You would select code 3, severe, if the patient had a score of 8 to 10 on a 10-point numeric scale, or an equivalent score on any of the types of scales I'd previously mentioned. Finally, you'll use code 9, pain not rated, if the patient had pain, but the patient's pain severity was not recorded in the clinical record. The last portion of this item is J0900D, which asks for the type of standardized pain tool used in the pain screening. So the response options for J0900D are listed on page 2J3 of your manual, and you'll notice that the manual includes a lot of examples of specific types of standardized tools for each category. So for J0900D, you're going to select code 1 if a numeric scale was used to conduct the pain screening. Examples include the 10-point numeric scale and the ESAS. You'll select code 2 if a verbal descriptor scale, such as the McGill Pain Questionnaire, was used. You should select code 3 if a patient visual scale was used to conduct the pain screening. Examples of a patient visual scale include the FACES pain scale or the distress thermometer. You should select code 4 if a standardized staff observational scale was used to conduct the pain screening, and an example of this type of tool would be the Pain AD. Finally, you'll use code 9 if no standardized scale was used to screen the patient for pain. So you may have noticed that J0900D, which I just went over, asks for the type of standardized tool that was used to screen the patient for pain. And I want to take just a moment and define for you what we mean when we say standardized tool, because it does have to meet several criteria. So first, it must be scientifically tested on a population with characteristics similar to that of the patient being assessed. So if you're assessing an elderly patient who is living at home, you might use a tool that had been tested on a community-dwelling elderly population. Second, a standardized tool includes a standard response scale. So for example, the 10-point numeric scale, patients always rate their pain from 0 to 10. Third, the standardized tool must be appropriately administered as indicated in the instructions. Finally, the tool must be relevant for the patient's ability to respond. So those of you who are familiar with the OASIS will probably recognize the definition of standardized tool that I just presented here. Moving on to tips for this item, we can see the tips for the pain screening item on page 2J3 in the Hospice item set manual. The first tip for this item states that pain screening must include evaluating the patient for presence or absence of pain, and if pain is present, the severity must be rated using a standardized tool. And I want to pause for a moment here and just contrast this definition of screening for pain to the definition of screening for shortness of breath that I presented yesterday. And you'll notice here that if the patient does have pain, you have to rate their severity using a standardized tool. And this is different from what I said yesterday about shortness of breath. In that case, you do not have to use a standardized tool, since clinical evaluation for shortness of breath is not well defined. Our final tip for J0900C states that we should select the code for pain severity based on the highest pain level recorded at the time of the screening. Let's look now at some examples for this item. Our examples start on page 2J4 in the Hospice Item Set Manual. And our first example is Situation A. For Situation A, the patient's clinical record shows that on August 12, 2014, the patient was very drowsy and appeared comfortable during the visit. There are no nonverbal signs of pain documented in the patient's clinical record. In Situation B, on page 2J4, the patient's clinical record shows that on August 12, 2014, the patient stated he was not in any pain and there were no complaints from the patient or family. So take a moment and think about these two situations that I just presented, situations A and B, and consider how you would complete J0900 for both of these examples. So for situations A and B, the correct course of action is to code 1 yes for J0900A to indicate that yes, the patient was screened for pain. For both situations, you would also enter August 12, 2014 as the date. The patient was screened for pain, and select code 0, none, for J0900C to indicate the patient was not in any pain. And since we selected none as the pain severity, we would skip over Part D of this item and move on to the next item as directed by the skip pattern. So why did we state that the patient was screened for pain in both of these situations? Thinking back to our definition of pain screening, a standardized tool need only be used to rate severity if the patient is found to have pain. In situations A and B, we see in the clinical record that the patient is not in any pain. In situation A, the patient was drowsy and appeared comfortable. There was no documentation showing the patient was exhibiting any nonverbal signs of pain. In situation B, the patient himself affirmed he was not in any pain. The last two examples for this item are situations C and D, and they start on page 2J4 in the Hospice Item Set Manual. In situation C, the patient's clinical record shows that on August 12, 2014, the patient reported abdominal pain of a 3 out of 10, with pain being a 6 out of 10 during the past 24 hours. So the documentation in situation C is pretty clear that the patient was screened for pain, but I want you to take a moment and consider the proper pain severity score to list for J0900C for this example. In situation C, the correct course of action would be to code 1 yes for J0900A to indicate the patient was screened for pain, and enter August 12, 2014 for the date. And again, I ask you to consider pain severity here because we see in the clinical record two different severity scores. So at the pain screening, the patient stated that they had current abdominal pain of a 3 of 10, with their pain being as high as 6 out of 10 during the past 24 hours. Remembering our tip, we should code the patient's pain severity at the time of the visit. So this means that we should select mild for J0900C, since the patient had mild pain or a 3 out of 10 at the time of the screening. For J0900D, we would select code 1 numeric for the type of standardized tool used. Our final example is situation D, and that appears on page 2J5. In situation D, the patient's clinical record shows that on August 12, 2014, the patient was unable to speak and that during the 20-minute observation, pain on a nonverbal scale was moderate to severe. Again, in situation D, it is evident that the patient was screened for pain, so we can answer yes to J0900A and enter August 12, 2014 for the date. But again, what should we list for their pain severity and the type of tool used? Thinking back again to our tip, we are supposed to record the highest severity at the time of the visit. In this example, the patient's pain was a range from moderate to severe. So the higher rating, severe, or code 3, is the correct severity rating to list for J0900C. For J0900D, you would select code 4, staff observation, for the type of standardized tool used. Although the specific clinical tool in this instance is not named, it is evident that the clinician used a standardized approach or clinical protocol to screen the patient. Our second item in Section J pain is J0910, which is the comprehensive pain assessment item. And this item again is used to calculate NQF number 1637, the pain assessment quality measure. Turning to page 2J6 in the Hospice Item Set Manual, you'll see the item-specific instructions for J0910. For this item, you are looking for evidence in the clinical record that a comprehensive pain assessment was conducted. A comprehensive pain assessment is more thorough than a pain screening and should address multiple aspects of the patient's experience of pain beyond just a rating of severity. So the first part of this item, J0910A, asks, was a comprehensive pain assessment done? And remember here that the two pain quality measures, NQF number 1634 and NQF number 1637, are paired measures. So you'll only complete the comprehensive pain assessment item, item J0910, if the patient screened positive for pain in the previous item. So if the patient was found to have pain, you should review the clinical record to see if there is evidence that a comprehensive pain assessment was conducted. Based on evidence found in the clinical record, you will answer either yes or no to J0910A. In order to answer yes to this question, you must see evidence in the clinical record that multiple aspects of a patient's pain were assessed. If you answer no to J0910A, you'll skip over the remaining parts of this item, parts B and C, and you would move on to item J2030, the screening for shortness of breath item. J0910B is the date of the first comprehensive pain assessment. So if you answered no to J0910A, you would record the date of the first assessment documented in the clinical record. J0910C is where you list the elements included in the comprehensive pain assessment. For J0910C, you're going to check all that apply to denote if the patient's pain assessment included 1, location, 2, severity, 3, character, 4, duration, 5, frequency, 6, what relieves or worsens pain, or 7, effect on function or quality of life. You would use code 9, none of the above, if you think a comprehensive pain assessment was done, but do not see any documentation that any of the above characteristics 1 through 7 were included in the pain assessment. So our tip for this item focuses on how elements of the pain assessment for nonverbal patients may be found in clinical record documentation. So it is possible to include elements of the pain assessment listed in J0910C for nonverbal patients. Clinical notes about assessment of nonverbal indicators of pain are acceptable. And slide 63, the table here on this slide, shows how nonverbal indicators of pain may appear in clinical record documentation. And I want to just take a couple minutes and walk through this table. So documentation about pain location for a nonverbal patient would include notes about the patient exhibiting nonverbal cues of pain for a specific location of the body, such as patient grimaced or shouted when clinician touched their right leg. Documentation of pain severity for a nonverbal patient may include notes about intensity of nonverbal expressions of pain or protective body movements. It could also include documentation of severity using a nonverbal standardized tool. A documented assessment that included duration for a nonverbal patient may include notes about how long a patient exhibited any nonverbal cues of pain, such as patient cradled right arm throughout the entire visit. Pain frequency for a nonverbal patient may include documentation about how often a patient exhibits any nonverbal cues of pain, such as most of the time, only at night, or intermittently. What relieves or worsens pain for a nonverbal patient may be included in the clinical record as any actions, activities, or positions that either make pain better or worse. And an example of this sort of documentation would be patient exhibits fewer nonverbal signs of pain when lying down versus sitting up. Finally, an assessment that included effect on function or quality of life for a nonverbal patient may include documentation about change in patient activity, such as family caregiver reports that the patient is no longer able to sit up in bed without moaning. So in addition to the documentation of nonverbal indicators that I just went over, caregiver report about any of the above characteristics is also acceptable documentation to consider when completing item J0910. Finally, coding can also be based on whether the clinician made an attempt to gather the information from the patient or caregiver. So say, for example, that for a nonverbal patient, the clinician asked the family or caregiver about pain location, and that family member stated, "I'm not sure," or "I don't know." You should still check one location for J0910C since the clinician attempted to gather that information. So we have two examples for this item. Our first example is situation A, which appears on page 2J8 in the Hospice Item Set Manual. For situation A, the clinical record shows that on August 12, 2014, the patient was unable to speak and was moaning loudly and grimacing during the visit. The clinician asked the patient's family how long the patient had been in distress, and the family stated that the patient had been moaning all morning and rarely looked comfortable. The family also stated the patient often clutched their lower abdomen. The patient was unable to move because of signs of distress when turning or getting up from bed. The family was uncertain what made pain worse or better. There's a lot of information in this example, so I want to walk through it together. First, we can answer yes for J0910A, since the clinical record clearly indicates a comprehensive pain assessment was conducted. we see documentation about several aspects of this patient's experience of pain beyond just a rating of severity. Next, we would enter August 12th, 2014 for the date. And since the patient is nonverbal, we're going to have to closely consider what we should include in Part C of this item. So we can check one location based on clinical record documentation that the patient was clutching their lower abdomen. This is specific to a location on the body, so it does give us an indication about location. Next, we can check 2, severity, since the documentation stating that the patient was loudly moaning and grimacing gives us an indication of the intensity of the patient's pain. We can also check for duration, since the note that the patient had been moaning all morning tells us how long the patient had been exhibiting nonverbal signs of pain. We can check 5, frequency, since rarely looked comfortable gives an indication of how often the patient exhibited nonverbal pain cues. We can check 6, what relieves or worsens pain, since although the family stated they were uncertain about what made the patient's pain better or worse, the clinician did ask about this particular aspect of pain. Finally, we can check 7, effect on function or quality of life, since the note about the patient being unable to move, turn, or get up from bed tells us that pain has affected or changed the patient's activity. Our final example for the pain section is situation B on page 2J9. In situation B, the clinical record shows that on August 12th, 2014, the patient rated their pain as throbbing and moderate with intermittent frequency. They stated movement made the pain worse and that their pain was affecting both their appetite and also their emotions. Relief measures that worked were heat, distraction, and massage. This situation is a little more straightforward since the patient is able to speak and the clinician could thus directly ask about several aspects of this patient's experience of pain. So in this situation, the correct course of action is to code 1 yes for J0910A to indicate that a comprehensive pain assessment was conducted. You would enter August 12th, 2014 for the date, and for J0910C, we can look back at the clinical record documentation to see what we should check for this portion. So we would check 2, severity, based on the documentation that stated that it was moderate. We would check 3, character, since the patient described their pain as throbbing. We would check 5, frequency, based on the patient report that their pain was intermittent. We would check 6, what relieves or worsens pain, since we know that heat, distraction, and massage improved pain, while movement made it worse. Finally, we would check 7, effect on function or quality of life, since we know that the patient's appetite and emotions are being affected by their pain. And this actually concludes our segment on pain today, so I'm now going to turn it back over to Francie, who is going to walk you through Section N medications.
Okay. I can sit up in here. So I'm Francie Rokoski from RTI International, and I'll be talking about Section N today, and then after the break I'll also be talking about Section F, Patient Preferences. In your manual, we're beginning on page 2N-1, and you can also refer to your item set and also to the Appendix C, which contains your item specifications or your quality measure specifications. So Section N addresses the use of bowel regimens for patients that are taking opioids. Opioids are commonly used in the management of pain and other symptoms in hospice patients, and constipation is one of the most frequent side effects related to the use of opioids. Most patients develop some degree of constipation after opioid initiation or dose increases. Reducing opioid-induced constipation has the potential to reduce patient discomfort and improve their quality of life. Patients do not develop a tolerance to opioid-induced constipation, and so clinical practice guidelines do recommend prophylactic bowel regimens for patients that are taking opioids. The intent of the items in Section N is to determine whether patients that are receiving opioids are also receiving a bowel regimen, or if they're not receiving a bowel regimen, that it is because there's a documented reason why a bowel regimen would not be appropriate for that particular patient. Section N contains items to collect data on two care processes: the initiation or continuation of PRN or regularly scheduled opioids, and the initiation or continuation of a bowel regimen for patients that are receiving opioids. The items in this section can be used to calculate the NQF measure 1617, and the NQF measure 1617 is the percentage of patients treated with an opioid who are prescribed a bowel regimen or who have documentation why a bowel regimen is not needed. You can find details about the quality measure in Appendix C in the Hospice Item Set Manual on page 8. And this measure was initially developed as part of the ACOVE measure set and then was endorsed by NQF in 2012 for use in hospice. So we'll take a look at the first item in your section, or in this section, and in your manual, I'm still on page 2N-1. The first item is N0500. N0500 asks, was a scheduled opioid initiated or continued? And based on a review of the clinical documentation, you would choose one of the two possible response options. You would select code 0 or no if the clinical record indicates that a regularly scheduled opioid was not initiated or continued from a previous care setting. And if you selected code 0 or no, you would then skip to item N0510, which asks about PRN opioids. You would select code 1 for N0500 if the clinical record indicates that a regularly scheduled opioid was initiated or continued from the previous care setting. And if you selected code 1 for N0500, you go on to N0500B. Before I talk about N0500B, though, I would like to just point out a few things at this point. As we go forward in this section, you'll notice that we have N0500, which pertains to the regularly scheduled opioids, and we have N0510, which pertains to the PRN opioids, and we'll get to that item in a moment. You'll also notice that these items talk about opioids that were initiated by the hospice or continued by the hospice in cases where the patient is admitted to hospice and is already taking an opioid. Also, I want to tell you what we mean by a scheduled opioid initiated or continued. Treatment initiation or continuation is defined as the date that an order was received, and an order could be written or verbal. So now we'll talk about N0500B. For that item, based on the review of your clinical documentation, you would enter the date the scheduled opioid was initiated or continued. Now, it is possible that a patient will have received various regularly scheduled opioids over time, and you would enter the date on N0500 that the first opioid treatment was initiated. It's also possible that a patient will have received both scheduled and PRN opioids, either simultaneously or in sequence. This item, N0500, asks only about the regularly scheduled opioids. Remember that our next item, N0510, pertains to the PRN opioids. So we have some tips for completing N0500. Opioids are used to treat several patients' symptoms, including pain and dyspnea. Remember that a patient is likely to experience bowel side effects if an opioid is started for any reason. For most patients, clinical guidelines indicate that a bowel regimen should also be initiated. For item N0500, you should select code 1, yes, if there's documentation that the patient was taking a regularly scheduled opioid for any reason. It is possible, once again, that the patient may have received multiple opioids, both PRN and regularly scheduled, and you are completing N0500 based on documentation regarding the regularly scheduled opioid treatment. So now we'll turn to item N0510. N0510A asks, was a PRN opioid initiated or continued? And based on your review of the clinical documentation, you would choose one of the two response options for this item. And you would select code 0 or no if the clinical record indicates that a PRN opioid was not initiated or continued. And you would select a code 1, yes, if the clinical record indicates that the patient was receiving a PRN opioid. In N0510B, you would enter the date the PRN opioid was initiated or continued. Now, if the patient received multiple PRN opioids over time, you would enter the date that the first PRN opioid was initiated or continued. It's also possible that the patient received both a PRN and a regularly scheduled, as I said before. This item, N0510, is only looking at the PRN opioid. And remember, if they were taking a regularly scheduled opioid, you've already answered about that in item N0500. So again, some tips for this item, very similar to the last, which is that opioids are going to be used to treat multiple patient symptoms, and this item is looking for opioids that would have been initiated for any reason, whether it's an opioid that's regularly scheduled or PRN. If an opioid is initiated, we're looking for it in section N. Okay. The clinical guidelines do indicate that a bowel regimen should be initiated for most patients. For item N0510, you should select a code 1, yes, if there's documentation that the patient was taking a PRN opioid for any reason. And again, it might be possible that they're receiving multiple opioids, both PRN and regularly scheduled. And you're completing this item, N0510, based on the documentation regarding the first PRN opioid treatment that was initiated or continued. So now we're going to move on to the item related to the bowel regimen, and that's item N0520. And in your manual, that would be on page 2N-3. The first thing to notice about this item is that you only complete it if your response to N0500 or N0510 was yes, or a code 1, which would have indicated that the patient is receiving either a regularly scheduled or a PRN opioid. This is a really important point, so I want to reiterate. This means that if there's no documentation that the patient is receiving a regularly scheduled opioid or a PRN opioid, as indicated in N0500 or N0510, you would not complete N0520. So it is true that patients may receive bowel regimens for other reasons besides them being on an opioid. These bowel regimens are not captured by this item because they're not part of the measure specifications for NQF 1617. You'll remember that the hospice item set is not a patient assessment, but rather it's a set of data items that are collected and can be used to calculate specific NQF-endorsed measures. The NQF 1617 measure is concerned with the initiation of a bowel regimen for patients receiving opioids. It is not concerned with bowel regimens that may be given to the patient for other reasons. And therefore, the hospice item set is only asking about bowel regimens if a patient is receiving opioid therapy. So for patients receiving an opioid for any reason, N0520A is looking for evidence that a bowel regimen was initiated or continued, and N0520B records the date the bowel regimen was initiated or continued. For this item, you have 3 response options, and you would review the clinical record documentation, and you would select 0 or no if the clinical record does not include documentation that a bowel regimen was initiated or continued from the previous care setting. If you selected code 0, no, you would then skip to Z0400, the signatures of the person completing the record. For N0520A, you would select a code 1, no, but there is documentation of while a bowel regimen was not initiated or continued. If you find clinical documentation that a bowel regimen was if there's no clinical record documentation that a bowel regimen was initiated or continued, and there is documentation as to why it was not initiated or continued. If you selected a code 1, you would then skip to item Z0400. Now, documentation of why a bowel regimen was not initiated or continued could include clinical contraindications to the use of a bowel regimen, or it could include documentation that a patient was offered but refused a bowel regimen. We'll get into the specifics of this item in just a moment. We'll get into some additional details. For N0520A, you would select a code 2, yes, if the clinical record includes documentation that a bowel regimen was initiated or continued from the previous care setting. And if you selected a code 2, you would go on to respond to N0520B to enter the date. So I'm going to give some tips here and definitions. A bowel regimen may include, but is not limited to, laxatives or stool softeners, high-fiber supplements, enemas, suppositories. And if you find orders or other documentation that any of the above bowel regimens were initiated, you should select a code 2 for N0520A. Orders may be for regularly scheduled or for PRN use of the bowel regimen. There are also times when a bowel regimen is clinically contraindicated. You might find documentation in the clinical record about possible contraindications, such as the patient has a bowel obstruction or ileus, the patient has diarrhea, the patient has no bowel function, the patient has a colostomy or ileostomy, the patient has nausea or vomiting, there's recent abdominal surgery, or the patient is taking nothing by mouth. There are also times where you might offer a patient a bowel regimen, but they refuse the treatment that you've offered. And documentation of a patient refusal or a clinical contraindication, such as the ones I mentioned a moment ago, would be sufficient to select code 1, no, but there's documentation of why a bowel regimen was not initiated or continued for item N0520A. Remember that this measure is specified such that selecting a code 1 or 2 meets the intent of this quality measure, which in both cases here, the hospice will have provided care that reflects clinical practice guidelines for bowel management in patients that are receiving opioid therapy. So you should select a code 0, no, if the clinical record contains no documentation that the patient received a bowel regimen and also contains no documented reason why a bowel regimen was not initiated or continued. Or it should contain documentation that the patient was offered a bowel regimen but refused treatment. Now, another thing to note here is where you might find the documentation in the clinical record to accurately respond to this item N0520A. An actual order to initiate or continue a bowel regimen would likely be pretty easy to find in the clinical documentation. However, documentation of clinical contraindications may be more difficult to find. They could be in, the gastrointestinal assessment section of your record, or elimination status, or bowel function, or elsewhere, depending on your hospice's usual practices regarding documentation of patient assessment. So you might remember what Kim said yesterday. This particular section may be a good one to review thoroughly as you prepare to implement the hospice item set. Remember that she had mentioned yesterday about potentially mapping or matching items that are required, things you need to know to respond to items on the hospice item set, and make sure that your existing documentation within your hospice, that you can find where this information would be that you would need to respond to N0520A. So again, this mapping and matching may help you to identify where in your particular hospice's clinical record you would find the documentation to support responding to N0520A. Okay, as with our other sections, we're going to go through some examples. We'll start with situation A, which is on page 2N-5 in your hospice item set manual. So in this case, you find documentation, you find an order from August 13th, and it shows oxycodone 10 milligrams by mouth every 4 hours, PRN for pain. And you also see clinical documentation from August 13th that shows that the patient has diarrhea. So think for a moment now what codes you would select for N0500, N0510, and N0520. So for N0500A, was a scheduled opioid initiated or continued, you would select a code 0, no, because the patient's order is for PRN opioids, not for a regularly scheduled opioid. So you would not record a date in N0500B, and you would move on to N0510. For item N0510A, you would select a code 1, yes, because the order shows the patient is receiving a PRN opioid. And you would record the date in N0510B as August 13th, because that's the date of the order. In N0520A was a bowel regimen initiated or continued. And for this one, you would select code 1, no, but there is documentation of why the bowel regimen was not initiated or continued. Because even though the patient is on a PRN opioid, the clinical record indicates that the patient also has a clinical contraindication, in this case, diarrhea. You wouldn't enter a date in N0520B, and you would skip to item Z0400. So to reiterate here, the intent of the items in this section is to determine whether patients receiving opioids are also receiving a bowel regimen, or if they're not receiving a bowel regimen, there is a documented reason why a bowel regimen is not needed or appropriate for that patient. Reasons for not initiating or continuing a bowel regimen could include a documentation of a clinical contraindication or the patient's refusal of a bowel regimen that was offered. So let's look at situation B. In this situation, there's an order on July 23rd, which shows morphine, 4 milligrams per hour through an IV continuous, with 2 milligrams IV PCA every 15 minutes as needed for breakthrough pain. There's also clinical documentation on July 23rd that shows last bowel movement was 5 days ago, and the patient is complaining of abdominal discomfort. And you also find an order in the clinical documentation that's dated July 24th, which shows polyethylene glycol, 17 grams, by mouth with a full glass of water. So we'll pause again, and you can think through which codes you might select for N0500, 510, and 520. So for N0500 in this situation, it's asking for was a scheduled opioid initiated or continued, and you would select code 1 or yes because you found an order for continuous morphine. In N0510A, you would also select a code 1 yes because there's also an order for PCA as needed for breakthrough pain. And you would record the date as July 23rd in N0510B. In N0520A, was a bowel regimen initiated or continued, you would select a code 2, yes, and that's because you also found an order for polyethylene glycol. For N0520B, the date of the bowel regimen initiation or continuation, you would enter July 24th. The clinical record documentation in this case indicates that the patient was on an opioid, morphine, both regularly scheduled and PRN, and that a bowel regimen was initiated. This situation also shows you what to do if you have a patient that is both on a regularly scheduled and a PRN opioid. Also, in this case, it was easy to find the documentation of the bowel regimen since there was an order written for polyethylene glycol. This may not always be the case, and as I mentioned before, this section in particular might be good for mapping or matching items from your usual hospice documentation so that you are easily able to find the information you need to complete this item. We'll take a look now at section N, example situation C, and this one is on page 2N-6 of the Hospice Item Set Manual. The patient's clinical record in this case indicates that there's a note on August 13th showing that the patient's last bowel movement was 5 days ago, and the patient is complaining of abdominal discomfort. And there's an order dated August 13th that shows polyethylene glycol, 17 grams by mouth, with a full glass of water. And what codes would you select in this case? So an NO500A was a scheduled opioid initiated or continued. You would select code 0, no, because you didn't find any documentation that this patient is receiving a regularly scheduled opioid. And you would move on to NO510A, was a PRN opioid initiated or continued. And you would also select code 0, no, because you didn't find any documentation that the patient is receiving a PRN opioid. For NO520A, you wouldn't complete this item. And this is because you don't complete NO520A unless the patient is receiving an opioid. And that means unless you responded 1 to either item NO500A or NO510A, you should not complete NO520. This is kind of a trick example to see if you were paying attention to what I said about that particular item where there is a skip pattern in this section. Okay, so that actually brings us to the end of the presentation about this particular section. Take a moment now. I think you received index cards if you're here in the audience. Write down your questions about section N, and we'll come by and pick those up, and then we'll do a Q&A after we take a break. We'll take about a 25-minute break or so. We'll reconvene shortly after 2. Thank you. Okay, welcome back, everybody. So we're going to do a question and answer session now that will cover Section J, pain, and Section N. You all contributed a lot of good questions, so we won't be able to get to all of them. If your question is not answered during the session today, we are logging all of your questions in the help desk now, and so you'll receive an email response to your question, okay? After we go through this question and answer session, then we'll go into the last section, Section F of the Hospice Item Set Manual. Okay, so this first question is about Section J, pain. The question is, do you have a list of specific standardized pain tools which can be used? For example, the Edmonton scale. So the items on the hospice item set do not dictate which clinical tools are selected and used by hospices for pain screening or assessment. The hospice item set is not intended to dictate clinical practice. The hospice item set is intended to capture previously collected patient-level information from the clinical record. So any tool that fits the definition of standardized that we provided in the presentation and is also in the Hospice Item Set Manual should be considered in selecting your response to items in Section J, pain. The definition we provide in the manual is on page 2J-3, and that definition is that a standardized tool is one that has been scientifically tested on a population with characteristics similar to that of the patient being assessed, and that includes a standard response scale, for example, a rating scale from 0 to 10. The standardized tool must be administered as indicated in the tool's instructions and must be relevant for the patient's ability to respond. Second question for Section J. For J0900, if a screen must include presence and severity, when would item C, so J0900C, ever be reported as 9? And in theory, if the patient had pain, item C should not be reported as 9 because a screening must include evaluating for the presence of pain and, if present, the severity. Now we'll answer a lot of questions about Section N. The first presents a situation. And in this question, the referring physician ordered morphine 3 days prior to admit. So let me start that again. The referring physician ordered morphine on the 13th of September, 3 days prior to the patient's admission to hospice. The hospice is continuing that morphine and received the order from the physician on September 15th. So that's 1 day prior to the patient admission, which was on September 16th. So which date would the hospice use as the initiation date? Would it be the 15th or the 16th? So in this case, you would use September 16th date because you can't initiate or continue a medication before the patient is actually admitted. September 16th, which is the day of the patient admission, is when you actually initiated or continued the treatment. Even if you have recorded the order in your hospice system, you cannot initiate it. On the 16th, that is when the hospice assumes the responsibility for what the medication treatment is actually going to be for that patient. The second question is, if a patient is on a scheduled opioid, does the bowel regimen also have to be scheduled, or can it be PRN? And the answer is that the bowel regimen can be PRN or scheduled. The next question is, can a bowel regimen include non-pharmacologic interventions, such as warm or hot liquids, prune juice, fruit paste, And the answer is yes. The next question is, please clarify page 2N-5, example B. If a patient was on a bowel protocol as of July 23rd, date of admission, and an opioid is initiated on July 29th as a PRN opioid, you would continue the bowel regimen, correct? Do you need to see documentation in the clinical record that the bowel protocol was reviewed or updated in correlation with the initiation of the opioid? And the answer is yes. When initiating an opioid, the documentation should reflect that the hospice reviewed whether the patient should continue the bowel protocol. The next question is, if a PRN opioid is on the hospice standing orders, would that be an automatic yes to item N0520A for every patient that's receiving an opioid? And the answer to that is no. Standing orders should be considered in responding to N0520A only if they were initiated. The next question is, if a patient has a PRN opioid ordered for anticipation of symptoms, but has never used the opioid, do we still answer N0510A as yes? And again, standing orders should be considered in responding to item N0520A only if they were initiated. Are hospices expected to hold the record open or change the responses on the hospice item set if an opioid is initiated after the hospice item set is completed, but before the deadline of completion at 14 days after admission? This gets back to the same question we've heard multiple times. So for items in section N, you can change your response to the items if a patient's clinical documentation changes. Remember that items in section N are not asking for the first prescribed opioid, and this is why section N is different. The items in section N is different than the items in other sections, such as section J, pain, and section J, dyspnea, where we are looking for the first documented. Okay, so section N is slightly different. The next question is, where would you find the date for a bowel regimen initiated if there was no order? Since the bowel regimen can be any reference to avoiding constipation. So this also gets at the issue if you are looking for documentation of a non-medication intervention as a bowel regimen. So the answer is that it depends on your hospice's particular documentation approaches. As I mentioned before, the documentation of a bowel regimen, and particularly non-medication bowel regimens, could be found in various parts of the hospice clinical record. This is why it might be helpful to map your hospice's usual documentation approaches to the items in section N in particular. And the last question is, how do we document the situation where, during the initial nurse assessment, it is determined that an opioid is needed, but we do not have physician orders yet? We get the actual order the next day. Do we use the date of the initial assessment or the physician order date? And in this case, the answer is you would use the physician order date in this situation. Okay. That's the questions and answers for section J and N. And as I said, we'll respond to additional questions that we received via email, and you'll receive a response from the help desk. Okay. So now we're going to switch gears. And I'm going to put my thing there. And we'll talk about Section F, preferences. In your manual, this section begins on 2F-1. So an important aspect of hospice care is the interdisciplinary approach toward providing care for the physical, the psychosocial, and spiritual need of the patients and caregivers. Items in this section, Section F, pertain to the patient's preferences regarding life-sustaining treatment and care for spiritual or existential concerns. The items in this section are intended to capture the process of eliciting or attempting to elicit a patient's preferences regarding their care. Patients who are given an opportunity to express their preferences are more likely to receive care that's consistent with their values. The items in this section do not represent an exhaustive list of patient preferences that hospices should consider, and a completion of this section does not replace a thorough and ongoing assessment and discussion of patient preferences throughout their time in hospice. Because patient preferences may change over time, it's important that hospices engage patients and caregivers and/or their responsible parties in reaffirming or eliciting preferences for care. This means that the hospice should engage the patient, their caregivers, or responsible party in a discussion of topics such as their preferences for life-sustaining treatment and their needs related to spiritual or existential concerns. Because patient ability to engage in these discussions can change rapidly and their preferences are central to care planning, preferences should be understood by the hospice in the early days of hospice care. Preferences are best obtained from the patient directly or the caregiver or responsible party if the patient cannot self-report about these topics. So Section F pertains to the hospice patient's preferences for life-sustaining treatments and for spiritual care. And again, items in this section are intended to capture the process of eliciting or attempting to elicit patient preferences. The items in this section are used in the calculation of two corresponding NQF-endorsed measures, the NQF number 1641 and a modification of the NQF 1647 measures. The items related to the NQF measure 1647 specifically ask about whether the patient or caregivers were asked about their spiritual or existential concerns. Appendix C of your manual contains the logical specifications for the corresponding quality measures. NQF 1641 is the percentage of patients with documentation of a discussion or attempted discussion about life-sustaining treatment preferences. The modified NQF 1647 measure is the percentage of patients with documentation of a discussion or attempted discussion about spiritual or existential concerns. Now, a note about the NQF 1647, this measure is considered modified, and that modification is related to the numerator time window. You'll notice in the measure specifications in Appendix C, this measure is specified with a numerator condition that can be met at any time during the patient's hospice episode of care. CMS has opted to include the relevant items for this measure in the HIS admission, and that is, of course, submitted to CMS earlier in the episode of care and does not look back over the entire episode of hospice care. So as a result, this measure is considered a modification of the currently endorsed NQF measure 1647. Okay, so we're going to start with the first item in this section. This appears on page 2F-1 in your manual, and it's item F2000, CPR preference. For item F2000, you're looking for evidence in the clinical record that the hospice discussed or attempted to discuss the preferences regarding CPR with the patient or responsible party. This item does not consider what the patient's actual stated preference is. The item reflects only whether or not the patient and or caregiver or responsible party and the hospice discussed this important topic or attempted to discuss it. So I'm going to repeat it. This item does not consider what the patient's stated actual preference is. The item reflects only whether or not the hospice discussed or attempted to discuss CPR with the patient or the responsible party. So item F2000 asks, was the patient or responsible party asked about preference regarding the use of CPR? And based on your review of the clinical documentation, you would select one of three response options. Before I get into the response options, I want to draw your attention to the wording of the item. It is asking about whether the patient or responsible party was asked about their preference. Again, this is because there are circumstances in which the patient is unable to respond to questions about their preferences. For items related to CPR or other advanced directives and life-sustaining treatment preferences, if the patient is unable to respond to the questions, the responsible party, such as the healthcare power of attorney, should be asked. And the item is about whether the patient or responsible party was asked, because the quality measure is specified to determine whether the hospice attempted to elicit the patient's preferences and not what the patient's actual preference was. So with respect to item F2000A, was the patient responsible party asked about preference regarding the use of CPR? Again, you have three response options. So based on your review of the clinical documentation, you would select a code 0 or no. If there is no documentation that the hospice discussed or attempted to discuss preference regarding the use of CPR with the patient or the responsible party. And if you selected no, 0, you would skip to item F2100, other life-sustaining treatment preferences. For F2000A, you would select code 1, yes, and discussion occurred if there is documentation that the hospice discussed preference regarding the use of CPR with the patient or responsible party. And you would select a code 2, yes, but the patient or responsible party refused to discuss if there is documentation that the hospice asked about preference regarding the use of CPR, but the patient or responsible party refused to discuss or was unable to discuss. So I want to take a moment now to point something out about Section F items, which is different than items in the other sections of the hospice item set. You will notice here that both a code 1 and a code 2 indicate yes that the hospice discussed or attempted to discuss the topic with the patient or the responsible party. This means that selecting a code 1 or 2 as your response to this item meets the intent of the quality measure as it's specified. Now, code 1 applies to situations where there is documentation that the hospice brought up the topic and there was a conversation with the patient and or their responsible party. The conversation may have been very brief, and it may or may not have included the patient or responsible party actually stating a preference or confirming a previous preference. The important thing, again, is that the hospice kind of opened the door for a discussion of this topic, and there is documentation that the patient or the responsible party engaged with the hospice in a discussion of this particular topic. A code 2 would apply to situations where there is documentation that the hospice attempted to have a conversation with the patient or the responsible party, but no conversation really took place. So this could be because the patient or the responsible party just flat out refused to talk about the topic. That means the hospice brought up the topic or tried to, but the patient or the responsible party said something like, I don't want to talk about this, or I can't even think about this, or I'm not going to talk with anyone except my priest about this. I'm not going to talk to you. So in this situation, you tried to have a discussion. You gave an opportunity for the patient to engage with your hospice about their preferences, but you were not successful in engaging the patient. Code 2 also applies to a situation in which the hospice attempted to discuss the topic, but the patient was unable to discuss because of their clinical status, and the responsible party also refused to discuss. A code 0 would apply to situations where there is no documentation that the hospice discussed or attempted to discuss this topic with the patient or the responsible party. There are legitimate reasons why this can occur. It can happen because the hospice is dealing with much more immediate reasons or needs of the patient with respect to their symptom management, or because there's a family crisis going on. There are times where this conversation simply cannot or even should not happen. And in these situations, you will not be able to find documentation in the clinical record that a conversation either took place or was attempted. And in those situations, you would select a code 0. So as we go through the rest of this section, you will notice that the items in the section are all structured and worded similarly. They all begin with a question: was the patient or responsible party asked about a particular topic? And then you record the date that they were first asked. And this is because the intent of all the items in this section is to determine whether or not the hospice engaged the patient and or caregivers or responsible party in a discussion regarding their care preferences. Also, since the hospice item set is not a patient assessment and is not actually administered to the patient, the hospice does not have to ask the patient about these preferences using any prescribed language or certainly not the exact items on the hospice item set. So each clinical situation requires a patient and family-centered approach to obtaining this important information. The manner in which these topics are brought up with individual patients and their families or responsible parties is left to the best judgment of the clinician or clinicians that are providing care and is not prescribed by the items in Section F. Okay, so here are a few tips related to item F2000. So again, the intent of the item is to capture evidence of a discussion or attempted discussion about patient preferences regarding CPR. A discussion about CPR preference can be initiated by any member of the hospice staff or interdisciplinary group, or IDG, also sometimes known as the interdisciplinary team, or IDT. And as I just said, the manner in which this topic is brought up with the patient or responsible party is up to the clinician and is not prescribed by the items on the hospice item set. Orders alone or short statements in the clinical record, such as DNR or DNI, or full code, without evidence of a discussion or involvement from the patient or responsible party, are not sufficient evidence of a discussion and could not be used to select either of the yes responses to F2000A. So that would be a code 1 or 2. And this is because orders alone do not show that the patient or responsible party were involved in a discussion with the hospice about their preferences. If you find a POLST or a MOLST or another similar form that's completed by the hospice and the patient after admission or during a pre-admission visit with your hospice, then that would be sufficient documentation to select one of the yes codes. So that, again, is a code 1 or 2. Since completion and signing such a document is evidence that the hospice and the patient or responsible party discussed these topics. Now, there are times where a patient may be admitted to a hospice with a pre-existing DNR order or a POLST or similar form. And in this circumstance, the hospice should reaffirm and document that the patient's preferences were reviewed and are still current. Reaffirming the patient's preferences means that the hospice engaged the patient or the responsible party in a review and a discussion of the POLST form. So in practical terms, this means that you would select a code 0 no if all you find in the hospice clinical record is a POLST form from a hospital or other prior care setting. You would select a code 1 yes and a discussion occurred if you find the POLST form and there's documentation in the clinical record that a hospice clinician reaffirmed that the preferences on the POLST form are the patient's current preferences. Or if the hospice actually completed the POLST form with the patient or the responsible party, you would also select a code 1 yes and discussion occurred, because in completing these forms and entering signatures of patient or responsible party, that would demonstrate that an exchange occurred between the hospice and the patient or responsible party about these preferences. You would select code 2 yes, but the patient or responsible party refused to discuss if you find a POLST form and there's documentation that the hospice attempted to discuss it with the patient or responsible party, but they were unable or refused to discuss. If a clinical record is ambiguous as to whether the hospice reaffirmed patient preferences that are documented in a pre-existing order or a POLST, you should select code 0 or no. So let's look at some examples. These begin on page 2F-3 of the hospice item set manual. So in situation A, the patient was admitted on August 1st, 2014. There is a clinical note dated August 1st that shows, talked with the patient about preferences for CPR. Patient states they are not sure. They request time to think and wants to discuss later. Another clinical note dated August 5th shows, discussed patient's preference for CPR. Patient stated preference for DNR, DNR order signed, and in clinical record. Think for a moment about which code you would then select for item F2000A. So in this situation for F2000A, you should select 1, yes, and discussion occurred, because although the patient did not state a preference regarding CPR at the first visit, a discussion did occur. The hospice opened the door for a discussion, and the patient did engage in a discussion. It was a brief discussion, and they did not state a preference, but that is not part of the consideration for what this item on the hospice item set is looking for. For F2000B, the date, you should enter August 1st. And this is that because although the patient did later state a DNR preference on August 5th, F2000 should be completed based on the first dated discussion or attempted discussion in the clinical record. And in this case, that was on August 1st, 2014. So let's say instead that the hospice clinical record shows that the nurse tried to talk to the patient on August 1st, but the patient adamantly refused to discuss the topic, saying, "I don't want to talk about this." And in this case, you would select a code 2. Remember that both a code 1 and a code 2 indicate that, yes, the hospice attempted to discuss the topic or discussed the topic with the patient. So let's look at situation B. In this situation, the patient is admitted on August 1st, 2014, and the clinical record for the patient includes a DNR order, which was signed in a prior care setting, and it's dated July 15th. So what would be the code for this item? So for F2000A, you should select code 0 or no, and you would not enter a date, but skip to the next item, F2100. And this is because in this situation, the patient has a recently dated DNR order, but it was signed in the previous care setting. There's no documentation in the hospice clinical record to indicate that the hospice reaffirmed the patient's preference. So now let's say you had found documentation that said DNR order confirmed with the responsible party, patient's daughter. In that case, you would have clinical documentation that would select or would support the selection of code 1, yes, and a discussion occurred, since now the documentation shows that the hospice reaffirmed a prior stated preference. So now we'll take a look at the next item in the hospice item set. This is item F2100, Other Life-Sustaining Treatment Preferences. In your manual, we're on page 2F-4. So for this item, you're looking for documentation in the clinical record that the hospice discussed or attempted to discuss preferences regarding life-sustaining treatments other than CPR with the patient or the responsible party. F2100A asks, was the patient or responsible party asked about preferences regarding life-sustaining treatments other than CPR? And based on your review of the clinical record, you select one of 3 response options. You would select a code 0 or no if there's no documentation that the hospice discussed or attempted to discuss preferences regarding any life-sustaining treatments other than CPR with the patient or responsible party. And if you selected a code 0 or no, you would then skip on to item F2200. You would select code 1, yes, and a discussion occurred, if there is documentation that the hospice discussed preferences regarding any life-sustaining treatment other than CPR with the patient or responsible party. And you would select a code 2, yes, but patient or responsible party refused to discuss, if there is documentation that the hospice asked about preferences regarding any life-sustaining treatment other than CPR, but the patient or responsible party refused to discuss. So as before, both a code 1 and a code 2 indicate yes, that the hospice discussed or attempted to discuss the topic with the patient or the responsible party. And as before, a code 1 would apply to situations where you have documentation that the hospice brought up this topic and there was a conversation with the patient or the responsible party. It may have been a brief conversation. The conversation may or may not have included a patient or responsible party's statement of their actual preference. But the important thing for the purposes of the item in the hospice item set is that the hospice opened a door for the conversation, either elicited or attempted to elicit the patient's preferences regarding life-sustaining treatments other than CPR. Code 2, again, would apply in situations where there is documentation that the hospice attempted to have a conversation with the patient or the responsible party, but no conversation really took place. And again, this could be because the patient or the responsible party just flat out refuse to discuss this topic. It could also apply to situations in which the hospice attempted to discuss the topic, but the patient was unable to discuss because maybe of their clinical status, and the responsible party also refused to discuss. And a code 0 would apply to a situation where there is no documentation in the clinical record that the hospice discussed or attempted to discuss the topic with the patient or the responsible party. And I want to reiterate that there are legitimate reasons why this occurs in hospice. It can happen, again, because there are immediate critical needs with respect to symptom management or a family crisis. And there are times where this conversation just cannot or should not happen. And in those situations, you're not going to find documentation that supports that the hospice either discussed these preferences with the patient or their responsible party, or even attempted to discuss them, and that happens as well. In F2100B, the date, so that would be, again, the date that the patient or responsible party was first asked about their preferences regarding life-sustaining treatments other than CPR. So here's a few tips for selecting the correct code for F2100. Again, as with the previous item, a discussion about preferences for life-sustaining treatments other than CPR can be initiated by any member of the hospice staff or the interdisciplinary group. And again, orders alone without evidence of discussion or an involvement from the patient or responsible party are not sufficient evidence of a discussion and cannot be used to select either of the yes responses for F2100A. If you find a POLST form that was completed by the hospice and the patient after admission, or even during a pre-admission visit, then that would be sufficient to select one of the yes codes, either a code 1 or 2, since completion of such a document is evidence that the patient and or responsible party discussed this topic. there is no comprehensive list of life-sustaining treatments. Treatments that are life-sustaining for one patient may or may not be considered life-sustaining for another patient. Documentation in the clinical record indicating that a member of the hospice interdisciplinary group discussed or attempted to discuss any life-sustaining treatment other than CPR, for example, things such as ventilator support, tube feedings, dialysis, blood transfusions, the use of antibiotics, the use of intravenous fluids, would be sufficient to code one of the yes options. And then again, I want to reiterate, as before, there are times when a patient may be admitted to hospice with a pre-existing order or a POLST or other similar form. And in this circumstance, the hospice must reaffirm and document that the patient's preferences, current preferences, regarding other life-sustaining treatments were reviewed and are still their current preferences. So in practical terms, this means that you should select code 0 or no if all you find in the hospice clinical record is a POLST form from the hospital or other prior care setting. And you would select a code 1, yes, and the discussion occurred, if you find a POLST form and there's documentation in the clinical record that a hospice clinician reaffirmed that the preferences on the POLST form are the patient's current preferences, or if the hospice actually completed the POLST form with the patient or responsible party. And you would select a code 2, yes, but the patient refused to discuss if you find a POLST form and there's documentation that the hospice attempted to discuss it with the patient or responsible party, but they were either unable or refused to discuss. And again, if the clinical record is ambiguous as to whether the hospice reaffirmed the patient's preferences that are documented in a pre-existing order or POLST form, then you should select code 0 or no for F2100A. So on page 2F-6 in the hospice item set manual, we have some examples. And we're going to start with situation A. And in this situation, the patient was admitted on August 1st, 2014. And there's a clinical note that's dated August 1st that shows, had a discussion with the patient about preference for use of IV fluids. Patient was hesitant and stated they weren't sure and wanted to discuss later. Told patient we could discuss at a later date. So in this situation for F2100A, which code would you select? So for 2100A, you should select a code 1, yes, and discussion occurred, because although the patient did not express a clear preference regarding the use of prolonged IV fluids, a discussion did occur. There is documentation that the hospice clinician engaged the patient in a discussion about their preference for the use of the IV fluids. For item F2100B, the date you would enter is August 1st, 2014. So let's look at situation B. In this one, the patient is admitted on August 1st, and the clinical record for the patient includes an order from the previous care setting, no life-sustaining treatments desired, and this order is dated July 15th, 2014. In this case, for F2100A, you should select 0 or no, because although the patient has a recently dated order regarding life-sustaining treatment preferences, it was signed in another care setting prior to the patient's admission to the hospice. there is no documentation in the hospice clinical record to indicate that the hospice reaffirmed that those preferences are still the patient's current preferences. In this case, for F2100B, you would not enter a date, and you would skip to the next item, F2200, hospitalization preference. Okay, so now let's say you had found a statement such as, desire to avoid all forms of life-sustaining treatments was confirmed with the responsible party, the patient's daughter. And let's say you found that in the documentation. And if that's the case, then you should have selected code 1, yes, and a discussion occurred. Since that documentation shows that a discussion took place and the hospice affirmed that the prior order still reflects their current preferences. Okay, so we'll move on to the next item, F2200, hospitalization preferences. We're on page 2F-7 in your manual. And for item F2200, you're looking for evidence in the clinical record that the hospice discussed or attempted to discuss preferences regarding hospitalization with the patient or the responsible party. And again, for this item, there are 3 response options. You would select a code 0 or no if there's no documentation that the hospice discussed or attempted to discuss preferences regarding hospitalization with the patient or the responsible party. And if you selected a code 0, you would skip to item F3000. You would select a code 1, yes, and discussion occurred, if you find documentation that the hospice discussed preferences regarding hospitalization with the patient or responsible party. And you would select a code 2, yes, but patient or responsible party refused to discuss, if there is documentation that the hospice asked about preferences regarding hospitalization, but the patient or responsible party refused to discuss or were unable to discuss. And again, you'll remember here that both a code 1 and a code 2 on this item would indicate yes, that the hospice discussed or attempted to discuss the topic with the patient or the responsible party. So as before, code 1 applies to situations where there is documentation that the hospice opened the door for a discussion with the patient or responsible party about the topic of hospitalization. And again, this discussion may or may not have resulted in the patient or responsible party actually stating a preference. The conversation may have been very brief, but again, the intent of the items in this section is to determine whether or not the hospice discussed or attempted to discuss these topics. A code 2 applies to situations where there's documentation that the hospice attempted to have a conversation, but no conversation took place. This could be, again, because the patient or responsible party just simply refused to discuss it, and this happens. So it could be that, you tried to bring it up, and the patient just shuts you down and says, I'm not going to talk about this with you. In this situation, you tried to discuss it. You were not successful in engaging the patient, so a code 2 would apply. The code 2 also applies to situations in which the hospice attempted to discuss the topic, but the patient was unable to discuss, and the responsible party also refused to discuss, and that happens as well. A code 0, again, applies to situations where there's no documentation that the hospice discussed or attempted to discuss the topic with the patient or the responsible party. And as we said before, there are legitimate reasons why this occurs. For F2200B, you would enter the date that the patient or responsible party was first asked about their preferences regarding hospitalization. A few tips about this item as well. As before, a discussion can be initiated by any member of the hospice staff or interdisciplinary group. And again, orders alone, without evidence of discussion or involvement from the patient or responsible party, are insufficient evidence of a discussion and cannot be used to select either of the yes responses to F2200A. If you find a POLST that was completed by the hospice and the patient after admission or even during a pre-admission visit, then that is sufficient to select one of the yes codes, since completion and signature on a document such as the POLST or MOST or other similar form would indicate that there is an exchange of information between the hospice and the patient and or their responsible party. There are times when a patient may be admitted with a pre-existing order or POLST or other similar form. And if a patient is admitted to the hospice with one of these forms, the hospice must reaffirm and document that the patient's preferences were reviewed and are still their current preferences. So again, in practical terms, this would mean that you would select a code 0 if all you find in the hospice clinical record is a POLST form from a hospital or other prior care setting. You would select a code 1 if you find the POLST form and there's documentation in the clinical record that a hospice clinician or someone from the hospice reaffirmed that the preferences on the POLST form are the patient's current preferences. Or you would select also a code 1 if the hospice actually completed the POLST form with the patient or responsible party. You would select a code 2 if you find the POLST form and attempted to discuss it with the patient or responsible party, but they were unable or refused to discuss. If the clinical record, again, is ambiguous, you're not certain as to whether the hospice reaffirmed patient preferences that were documented in a pre-existing POLST or other order, then you should select code 0 or no. So we have some more examples for you. In situation A, which is on page 2F-9. This patient was admitted on August 1st, 2014. There's a clinical note that shows, talked with the patient about preferences for hospitalization or readmission to the hospital. The patient was hesitant and stated they weren't sure. We told the patient could discuss it at a later time. So in this situation, for F2200A, you should select code 1, yes, and a discussion occurred, since although, again, the patient did not express a preference regarding the hospitalization, a discussion took place. And in F2200B, you would enter the date August 1st, since that is the date of this discussion. In situation B, you have a patient that was also admitted on August 1st, and the clinical record for the patient includes a POLST form that was completed in the prior care setting, and it indicates selection of comfort-oriented care and includes the desire to avoid hospitalization. And that POLST form is dated July 15th. In this case, for F2200A, you should select code 0 or no, because although the patient has a recently dated POLST form, it was signed in a prior care setting, and there is no documentation in the hospice clinical records that shows that the hospice reaffirmed the patient's preferences for comfort-oriented care and avoidance of hospitalization. In this case, you would not enter a date, but you would then skip to the next item, F3000, which is spiritual or existential concerns. All right, so let's say you had found, once again, some documentation such as all post-treatment preferences confirmed with the responsible party. In that case, you could have selected code 1, yes, since that documentation in the hospice clinical record would indicate that the hospice reaffirmed that preferences in a pre-existing order or post form are still the patient's current preferences. Okay, so I think you're getting the hang of this section. So we're going to throw in another example, and it's not in your manual. So in this case, we're going to make this up. We have a patient that's also admitted on August 1st, and the clinical record documentation shows that the hospice nurse went to their house on August 2nd, and the patient was unresponsive, and the patient's responsible party, the patient's daughter, refused to talk about the hospitalization preferences topic. There's another clinical note from August 4th, and it said, tried again to talk with the patient's daughter about preferences. She again refused to discuss. So what code would you select in this situation? So there's disagreement in the audience. Is it a 1 or a 2? Now people are changing their minds. So the correct response would be code 2. So remember that code 2 applies to situations in which there is documentation that the hospice attempted to discuss the topic, but the patient was unable to discuss because of, let's say, their clinical status. I mean, they just may not be able to discuss it, and the responsible party refused to discuss, and this happens. For the date here, you would enter August 1st, because that is the date of the first attempted discussion with the patient or responsible party. So although the clinical documentation shows the hospice tried again, maybe they tried on the 4th and the 5th and the 6th, the item on the hospice item set is only looking for the first time that the hospice tried to engage the patient or responsible party in a discussion about hospitalization. So you might be thinking about that August 4th date still. You might be thinking, well, they wouldn't talk about it on the 1st of August, but they did on the 4th. So wouldn't that be better for us to put in the August 4th date? The answer still is no. And here's why. The item asks again for that first discussion or attempted discussion. And I also just want to take this opportunity to point out again that this item is code 1 and a code 2 are both yes responses. And in those responses, the patient met the intent of the items and the measure reflected from section F. And that is an attempted discussion or documentation of an actual discussion with the patient or responsible party about these preferences. So we've come to F3000, which is the last item in this section. In this item, you're looking at page 2F-9, and this item is looking for evidence of a discussion or an attempted discussion regarding spiritual or existential concerns, and the date of the first discussion or attempted discussion. Again, this item does not consider whether the hospice followed up on any spiritual or existential issues through other care processes, such as referrals to a chaplain and so forth. The items on the hospice item set are intended to determine only whether or not the hospice attempted to elicit information from the patient or their caregivers about any spiritual or existential concerns they may have. Now, this does not mean that the hospice won't have numerous conversation with the patient and caregiver or caregivers about this topic. Remember that the hospice item set is not a patient assessment and does not replace a thorough and ongoing patient and caregiver assessment throughout their time in hospice. This item set is designed to capture data items needed to calculate NQF-endorsed quality measures for hospice. Now, you'll notice right off the bat that on item F3000, the language has changed. We're no longer asking about responsible party for this item. We're asking about caregiver or caregivers. And that's because this topic of spiritual or existential concerns is not a legal concept and does not require a legally responsible party's involvement if the patient is unable to state their preferences or concerns. And of course, this item is intended to reflect care provided to the hospice unit of care, which is the patient and their caregiver or caregivers. So F3000A asks, was the patient and or caregiver asked about spiritual or existential concerns? And based on your review of the clinical documentation, you would select one of three possible codes. You would select a code 0, no, if there's no documentation that the hospice discussed or attempted to discuss spiritual or existential concerns with the patient. You would select a code 1, yes, and a discussion occurred, if there is documentation that the hospice discussed this topic of spiritual and existential concerns. And again, you would select a code 2, yes, but patient or caregiver refused to discuss, if there is documentation that the hospice asked about spiritual or existential concerns, but the patient and or the caregivers refused to discuss or were unable to discuss. So you'll recognize that once again, these options, the structure of the response options are similar to all of the other items in section F. And so again, code 1 would apply in situations where there's documentation that you brought up the topic and had a discussion with the patient or caregivers, and it may have been brief, and you may or may not have done anything with the information you received, but you opened the door for a conversation and you engaged the patient and or their caregivers in a discussion of the topic. Code 2 applies where you tried to open the door for a discussion about spiritual or existential concerns, but you were not successful in engaging the patient or caregivers in a conversation. It can also apply to situations where a patient was unable to discuss and the caregivers also refused to discuss. Code 0 applies in situations where there's no documentation that the hospice discussed or attempted to discuss this topic with the patient or the caregivers. And again, there are really legitimate reasons why this happens. It could be a patient with a major medical crisis going on. It could be a very short patient stay in the hospice. There's reasons why sometimes this conversation cannot and sometimes even should not happen with the hospice and the patient or caregivers. And in those situations, you would use the code 0. In F3000B, again, you would enter the date of the first discussion or attempted discussion. And you'll recognize these tips. Again, similar to the preferences for life-sustaining treatment items, a discussion about spiritual and existential concerns can be initiated by any member of the hospice staff or the interdisciplinary group. Brief statements in the clinical record about the patient's religious affiliation would be insufficient evidence of a discussion and could not be used to select either of the yes codes for this item. Again, this item is intended to capture the evidence of a discussion or an attempted discussion of spiritual or existential concerns, and it does not capture whether or not interventions were initiated to address spiritual or existential distress. Also, there is no comprehensive list of spiritual or existential concerns. The hospice item set does not prescribe what spiritual or existential issues the hospice and patient and caregivers discuss or assess. This is left to the judgment of the hospice staff providing care for the patient and family. And we have some more examples. These begin on page 2F-11 on your hospice item set. So here in situation A, you find documentation on a social worker questionnaire from August 1st, and it shows patient's spouse in great deal of spiritual distress and would like to speak with a chaplain. A referral was made. So what code would you select? Okay, so I'm seeing lots of ones in the audience, and that's right. You would select code 1, yes, and discussion occurred, because the completed social worker questionnaire shows that the hospice engaged the patient and/or the caregiver in a discussion regarding their spiritual or existential concerns. Even if the clinical record does not contain documentation of a visit by the chaplain, you would still select code 1, yes, and discussion occurred, since the intent of this item, F3000, is to capture the initiation of a discussion about the spiritual or existential concerns. For F3000B, you would enter August 1st, 2014, since that's the date that the clinician recorded this conversation. In situation B, you have a patient whose initial assessment shows patient identifies their religious affiliation as Baptist. So you find this in the clinical record. What code would you select for F3000 in this situation? 0, that's right. So the correct code for F3000A would be 0, no, because clinical record documentation that only shows the patient's religious affiliation does not support that the hospice actually discussed spiritual or existential concerns with the patient and/or their caregivers. Again, remember that the intent of F3000 is to capture the discussion or attempted discussion about spiritual and existential concerns. And in this situation B, for F3000B, you would not enter a date and you would skip to the next item. So this was the last item in section F. I know that we've covered an incredible amount of information this afternoon, and it's a lot to digest. Take a few moments now to write down questions that you have on index cards, and we'll pick them up. I think we're going to have a break, and then I'll be presenting some questions and answers about section F. So let's do about a 20-minute break. Come back at about 3:40. Thanks.
right, everybody, we're going to finish up the day with some questions and answers that we received about Section F, preferences, and then we'll have a final wrap-up. So the first question we received states, my state does not use the POLST form. We use the MOST form or some other equivalent. Can that count for the preferences items F2000 through F2200? And the answer to that question is yes. Remember that if your hospice completes a MOST or POLST or other similar document, that the documentation should be considered in selecting the appropriate codes for items F2000, F2100, and F2200. If the patient came to hospice with an existing MOST, POLST, or other form or order that were completed in a prior care setting, your hospice should review, reaffirm, and document that the preferences contained in a pre-existing form are still their current preferences. To be counted as indicating preferences, the MOST or POLST form and accompanying documentation must not simply be an order signed by a clinician. Documentation must also include evidence of communication with the patient or patient surrogate, minimally their co-signature on the form. This specific example, again, is discussed on page 29 of the HIS. The second question asks, what's the difference between discussion occurred and refused to discuss? And remember, these are the response options for the items in Section F. So the examples that we gave state that when the patient does not state a clear preference, this should be coded as 1, yes, and discussion occurred. And the answer to this question goes back to the fact that the intent of the items in this section are to determine whether or not the hospice attempted to discuss preferences with the patient or the responsible party. It matters whether or not the hospice brought up the topics in this section. It does not matter if the patient or responsible party actually states a preference during the discussion. The discussion may be very brief. For example, the patient may say, I want to think about this some more and talk to you in a few days after I've had a chance to talk with my daughter. That's not a patient refusal. That is a short discussion. So in that instance, the hospice opened the door and the patient engaged and is now thinking and talking with their daughter about the topic. On the other hand, patients and responsible parties may refuse the opportunity to discuss their preferences, and this is their right. But even in that case, if there's documentation that the hospice made the attempt to discuss the topic, you should select code 2, yes, and patient or responsible party refuse to discuss. And the third question is related to that and asks, what are examples of refuse to discuss? So these are situations where the patient or responsible party flat out refuse to consider the topic and engage in a discussion with the hospice at all. Refusal to discuss is different and more rare than inability to make a choice about treatment during a discussion. Refusal to discuss is used only when patients say things like, I don't want to talk about this, or I'm only going to talk about this with my priest and not with you, or other statements that make it clear that the patient is not going to talk about this topic with the hospice. Remember, though, that the intent of the measure is to capture discussions or attempted discussion, so patient refusal to engage in the discussion does not adversely impact your score on the quality measure. Another question states, please provide further clarification as to your terminology of hospitalization preference. I'm specifically asking for clarification for our enrolled hospice patients for whom inpatient hospice care is offered, but for whom we do not use the hospitalization synonymously with inpatient hospice care. Hospitalization and inpatient hospice care are not synonymous. for purposes of item F2000. The measure is looking for hospitalization other than an inpatient hospice care. Our next question asks, if there is no list of what is considered life-sustaining treatment, how do I know if what is in the medical record is what you are looking for? And the answer to this question is that state laws may vary on the definition of this term, and therefore the determination of what would be considered life-sustaining has to be made by the hospice on a patient-by-patient basis. What's life-sustaining for one patient may or may not be life-sustaining for another. Now, the Hospice Item Set Manual does list some treatments that may be life-sustaining on page 2F5, but there could be others. That list is not exhaustive. You will respond to the item on the hospice item set based on the documentation in the clinical record and the clinician's definition of what is life-sustaining for that particular patient. The next question says, for F2000, which is CPR preference, if we find an order for DNR signed by the hospice physician, is that enough to select code 1 for that item? If there's an order in the chart from the hospice physician, doesn't that imply that a discussion must have occurred with the patient or responsible party? Would the physician have to write a clinical note that says the discussion happened? So orders alone or short statements in the clinical record, such as DNR, DNI, or full code, without evidence of a discussion or involvement from the patient or responsible party, are insufficient evidence of a discussion and cannot be used to select code 1 or 2 for F2000A. This is because an order alone does not show that the patient and or responsible party were actually involved in a communication with your hospice about their preference. It could be that the physician used prior documentation of a patient's wishes to write the order without discussing whether that documentation reflects the patient's current wishes. Therefore, the abstractor should look for documentation that indicates the patient's wishes regarding CPR. Therefore, the abstractor should look for documentation that indicates the patient's wishes regarding CPR were discussed with the patient or responsible party. That documentation could be in a clinical note, or it could be a patient signature on a document, such as a POLST form. The next question says, we usually discuss preferences at pre-admission visits with the patient and family or responsible party. Does this impact which codes we would select for the items in section F? Discussion of preferences at a pre-admission visit is acceptable, since these discussions are held between the patient and or responsible party and the hospice. If a patient is admitted with pre-existing orders, a pre-admission discussion should reaffirm the preferences that are documented in the pre-existing order. The next question states, for item F3000, what if you try to discuss spiritual issues with the patient and they refuse, but you are able to discuss spiritual issues with the caregiver, let's say his wife? What code should I select then? For this situation, you would select code 1, yes, and discussion occurred. The item does not require that the topic be discussed with both the patient and the caregiver. The next question states, for the hospice item set, is the information coming from the admission assessment form or from all disciplines forms, so things such as social worker questionnaires? And the answer to that is, if in your particular hospice, documentation about items in section F could be in other documentation besides an admission assessment form, you can consider documentation in other sources, such as a social worker questionnaire, when you're responding to items on the hospice item set. And our final question for section F states, and this was actually, we took a couple of questions we received and combined them into one question. And the general gist was we had more questions about how to respond to the items in section F if the topics in section F were discussed at a pre-admission or an educational visit. And again, if your particular hospice discusses these items prior to admission, you can use that documentation when you're completing section F. You would date section F items based on the date of the discussion or attempted discussion. And the specifications for the measures that are in Appendix C, and also the draft technical specifications, which are available on the cms.gov HQRP website, do allow for the collection of this information prior to the patient's admission date. So that was all of the questions for section F, and I'm now going to turn it over to Kim, who's going to do our wrap-up for today.
Thank you, Alexis. So just a reminder or two, if you are watching this by way of live streaming and you have unanswered questions, please feel free to send those questions into the Hospice Quality Questions website. Make sure that you include any slide number, chapter, section, item number, if that will help us, and it certainly will help us, so please be sure to put those identifiers in. And there are two help desks for providers, the Quality Help Desk and the Technical Help Desk. And if you don't have these numbers handy, just refer back to the PowerPoint slides, which are located on the Hospice Quality Reporting website under HIS. You'll find the slides, the manual, the one-page fact sheet, and some other really good information that will help you out in the process. So I want to also take this time to remind you that today is February 5th, and the deadline for the current quality reporting period is less than 2 months away. Okay, so that date is April 1st. So please be very cognizant of that date and make sure that you get your quality data into CMS so that you'll be within the deadline period. So on behalf of Robin Dow and the rest of the Hospice Quality Measures team, we'd like to thank everybody for their participation, for your attention, and we'll be talking to you again in the future. Keep in mind the technical training that will occur in May. More details will be forthcoming on that, but thank you very much for your attention.